Hi, my name is Colin King. I work for an organization called the Whiteness and Racial Equality Network. It's really a great privilege to deliver this workshop, which is week 4 of survivor research, lived experience in mental health. The workshop has 3 learning objectives. Firstly, by the end of this recording, you should be able to understand some of the key features and history behind service user research. Secondly, we're going to look at some of the controversies or concerns or issues that have arrived and challenges for doing survivor research. And we're going to look specifically at race equality in this presentation. Thirdly, you should be able to articulate the resources or support or toolkits needed for us in terms of the benefit for survivor research to have more respect and equality. In section 1 of this presentation, the form or the feature will be to understand a variety of definitions and some of the key features for survivor research. And the pictures actually illustrate some of the challenges that we will be addressing around Lardner, Joyce Lardner, very famous black feminist researcher in America who looked at how lived experience was actually reduced and denied and didn't give the sort of respect it deserved when looking at racism during the period of post-colonial society and racism in mental health work in the period of the 60s and the 70s. I think it's important in this presentation when we begin to look at what survivor research is, particularly from lived experiences, to own and look at your own lived experience. Um, my name is Colin King. I've been diagnosed with schizophrenia since the age of 17 years of age. Also at school, I have a lived experience diagnosis of something called being educationally subnormal. That happened to lots of black kids during the 70s and 80s. During my experience in the mental health system, I heard voices of concern and distress, and I got captured in a diagnosis called the Diagnostic Statistical Manual 5. What that manual did was deny my lived experience. And there you see the picture of Maudsley, where I spent on 4 occasions being sectioned under the Mental Health Act. I also sectioned people under the Mental Health Act and began to understand some of the features of lived experience and how that gets denied in mental health units like Maudsley Hospital. Because within that process, there's a real profound feeling that other people are researching your lived experiences, either to give you a diagnosis or also to fulfill some sort of research outcome. So lived experience becomes a capital. It becomes a way of people using it to define a method, a model that's not really centered to your particular experience and world. So lived experience or the development of lived experience has its origins in the work completed in some important people like Peter Brelford and people outlined in this book, the Survivor Research Document, where people got together and began to say, well, the way we are treated with lived experience is based upon a form of madness. So we had the emergence of mad studies who develop a theory of activism, which means that how do we look at how lived experience is actually misdiagnosed? What's the history and culture and the politics in which people begin to see the system as a system of madness? And mental illness and work with psychiatry begins to lead to a pattern and process where lived experience is marginalized. So how do we then ensure, whether it's neurodivergent or disabled people or people under protected characteristics, their lived experience is recognized as a survivor research process and model that should have equality and parity. So lived experience can be used as a knowledge. It means that the experience gives us the opportunity to develop a model, a framework to understand experiences in different frameworks. As it outlines in these 2 very small paragraphs, it's about a development of an academic framework, similar to when you're studying sociology or psychiatry or psychology. It gives you a different alternative model to clinical research, and it also enables lived experience to become the experts of their settings and their experiences. Two great books that you may consider looking at: Disability in Society, and a really good book that came out recently, Searching for a Rose Garden, which is a compilation of different people from a lived experience background talking about their experiences of doing the research, being respected for the research, and also looking at the impact of what a lived experience research model can actually offer. It's really important in this presentation, section 1, when we look at the reasons, importance, that lived experience is framed within the legal rationale. We now have major legislative changes that are now saying that lived experience is crucially important. The first paragraph here is from the Mental Health and Wellbeing Discussion Paper 2020, which they actually make a really important admission that there should be an elevation of the voices and perspectives of people with lived experience. They need to be seen in leadership roles. More importantly, which is probably the biggest challenge, is that they've got to have clarity with clinical leaderships as we move towards 3 outcomes: co-production, delivery, and evaluation of what we actually do. So this is really important. But also lived experience should be represented in all aspects of the clinical framework and the governance framework as well. Secondly, if we look at the Mental Health Use of Forces Act that came out in 2018 after the sad loss of Adebola Lewis. This is an act that was actually inspired by Adebola Lewis, and it says really importantly, read 2 words: equitable and reciprocal. It must be shared and given status. We need to understand the experiences, and it's based upon something called being person-centered. It is the foundation, the premise to good co-production. And co-production means to be given power and respect. So this is a really crucial change in lived experience. It is a legal rationale. So not only does lived experience has an important legal rationale, it needs to be represented as knowledge that we use to understand mental health practices, and mental health outcomes. And one of its important methods to underpin its work is qualitative phenomenological, which is the phenomena, the experiences. This is crucial because we're now talking about the first hand, the authentic experience of being in the mental health system, the choice that are given to people, how knowledge is gained from the process of how mental health is made sense of, and how that gain goes into second-hand and mediated sources. More crucially, phenomenology is the study of the experiences, and in effect, everybody has a lived experience. Clinicians have lived experience, but it's more likely applied to people who are the victims of mental health processes, and then to give them recognition, their experiences forms knowledge that should be used across all clinical professionals to use that, particularly in terms of a research process. So in terms of research, let's begin to break this down into different aspects of how lived experience can be used based upon existing framework. So the ontological is the way we make sense of the world. And we'll go into this a bit more detail. Objectivities is about things around facts, things we can measure. Constructionism is about how people put their reality together, how we make sense of ourselves as a black man who experiences mental health. And that really formulates around subjectivism. You as the subject, the individual, whether you be a researcher or a student, you're going through a particular process. The epistemology is about how do we make sense of it for knowledge. How do we actually transfer that into something called positivism, which is a science of the fact that we can say, look, I can measure this. I know it's taking place. But we may be more interested in interpretism. Really, basically, is how do people make sense? How do I interpret the fact that I'm feeling low and life is difficult, or I think because of my race I've been affected by my issues of mental health? And then we can look at more specific things that about the subject, the individual issues that may be linked to protective characteristics like feminism. We can talk about racism, disabilityism, lesbian and gay issues as well. Because in effect, what we want to get to is that we live in different parts in our world experiences, which is postmodernism. We live in a space in our home, in the community, in the hospital. But then we need to go into what type of methods will give us the best idea of understanding these processes. So action research is really about how people behave, their actions, their processes. We may look at a case, and in most parts the case will be the lived experience rather than the clinician. We may think that to get a better idea of what's taking place, we'll do some surveys, some focus groups, or we may even go on towards and do some ethnography. Let's watch and see, because the closer we can get to that experience, the closer we can get to something's grounded. Grounded, it's really about the person and the theories that help us to understand. And some of the methods we may use to get to that lived experience are questionnaires, asking people questions to measure relationships, interviewing people face to face so we know the difference between what they say and what they don't say. But then, how do we observe people in a live drama, in the reality of what's taking place for them? So in this section, I'm going to begin to make a division between what's on an unlived experience model that tells us more about what a lived experience research model is. An unlived research model is that you don't live it, you're actually observing it. And some people say you can't be scientific, you're getting too close to the reality you're interested in. And then most of those frameworks have developed through white male Eurocentric approaches to research. And even the models we use lead to particular deterministic outcomes. So the ontological will be more about objectifying something. We want to measure the experience of lived experience because we're looking at maybe some legal frameworks. We want to make sure that we're experiencing why is it black men, myself, are more likely to be given a diagnosis of schizophrenia as opposed to a white community that's given a label of personality disorder. We want to understand through a clinical framework or clinical research process how we diagnose lived experience. Not the experiences, but how we then diagnose it, the process of what we do. Because in effect, this is deductive. We know what we're looking for. We're looking for statutory labels, we're looking for diagnosis. And sometimes that can deny the lived reality and the lived experience. And this becomes system focus rather than a lived experience focus. The epistemological knowledge framework sometimes is focused on positivism. Yeah. Again, this is the science because we're looking at these legal frameworks. So we're not interested in the individuals, we're looking at patient, service users and carers. So that the identity for people with lived experience is always already given. It's determined. This is what makes a lived experience. The lived experience is also based upon clinical frameworks of mental disorder, Section 1 of the 1983 Mental Health Act. Because of that, we're looking for how people become the subject of the diagnosis. Not how people experience the diagnosis, how they're the subject of diagnosis. How can we measure the relationship between the diagnosis and the individual? And so this type of process is more of a consultative. We ask people questions rather, how are we going to co-produce why this is taking place? So some of the methods we'll often see in unlived experience models is surveys and case studies. Surveys is really important because the quantitative methodological framework gives people more validity on reliability of measurements. This begins to disempower lived experience to an illness. So we're really focused on the illness, the schizophrenia, the bipolar, the psychosis. And then that clinical framework, we're looking at matrices. How do we measure relationships between particular variables, which could be care plans, the risks, but we're not interested in patients' needs. In this research process, we're really interested in professional practice, not lived empowerment. And we can see this emerging in the legal changes to the Mental Health Reform Bill and the way funding has been given out to mainly white organisations to research the lived experience of black people in terms of why are black men more likely to be diagnosed with schizophrenia. And this raises a lot of concerns about what models are now emerging from this research model. And going back to Peter Brailsford, his concern raised in Med Studies, it's leading to a dominance of a biomedical. Biomedical is a medical approach. It's a scientific approach. We are putting people into categories of mental disorder. So the Mental Health Act is based upon the system change and not the person. And the clinical frameworks in which we use is not a lived experience framework or even an Afrocentric framework. It's very a Euro-American model, DSM-5 or ICD-10-11. Because in effect, this is not a real science in the conventions of a medical science. It's constructed by clinicians, which leads to an ideological bias. And the bias is against the lived experience. And it's really about system changes that enable people to diagnose rather than give back more power back to people with lived experience. The impact has been quite radical and concerning. And if we go back to the legal rationale we just discussed, it's led to the denial of lived parity, which means people with lived experience are not given equality in the frameworks used to actually look at their mental status rather than their mental disorder. It's mostly based upon something called public safety. Christopher Clunas is a very important case of a young black man in the 80s who killed a white person and led to the emergence of something called the CARE program approach. That was based upon the safety, the risk, and we actually can measure that risk in terms of lived experience welfare rather than lived experience empowerment. So it's based upon diagnosis as a form of control. And the lived experience is actually not actually giving power back to people to make decisions about their life. It's actually looking at the risk factors. So it reaffirms some really important values about people involved in lived experience who are not looking at these types of challenges. It's equality, but it's not about equality to people with lived experience. So in this section, for you students that are beginning to embark on a really important part of your academic career, and some of you may have mental health issues, you're going to look at what a lived experience model aims to do. And it's slightly different. We're going to use the same sort of framework. So ontologically, it's looking at the subject. The subject is the individual. But really it's about how they see their world, how they're under stress and moods and challenges, how that can be informed by their identity and their heritage. So it's livism. It's about how people live their world. And the legal framework we're looking at is a social care model as opposed to the mental health model. It's the social challenges and the models of practices, which is really based upon somebody called Maslow, based upon needs. The clinical framework is not diagnostic. It's really about a needs-led assessment. And the concern here, lots of research look at service provision and don't even look at needs. Needs inform service-led provision, and this is really crucial to what we call in the research process inductive. So we're inducing, we're trying to get the ideas, we're asking the right questions, we're trying to find out what the subjective is. We're not asking them who needs counselling, who needs housing. We're trying to find out what is the lived reality. That's what the lived experience, taking you closer to the reality of the experiences. So it's really based upon three important components in terms of policy decisions in research. We're now looking at parity and equality, but also we're looking at social justice. If we're looking at black men and diagnosis, we're not concerned, is it they're more mad, or is it something about the system, the social injustice of the mental health system that creates these types of outcomes? And to get to that challenge, to get to that understanding, epistemologically, we need to look at different ways of understanding it. Postmodernism gives us a wider understanding of people's historical heritage. And then we can use more flexible lived experience models that equates and are equal to protective characteristics, whether it be gender and feminism, race and ethnocentricity, LGBT and queer rights and experiences. And the thing I'm talking about, the otherism. We're talking about the otherism, the people who've been denied the lived experiences. Because effectively what we want to do was came out in some of the diagnostic frameworks, particularly in terms of criminalisation of sexuality, the criminalisation of black men with schizophrenia. We want to decriminalise these labels and begin to look really much more deeper at the complexities of what is lived as an experiences. And so our diverse models need to look at diverse models in terms of how we assess people and our care planning. So ultimately, Carl Rogers, who can be used across the protective characteristic spectrum, is looking at the person, the centeredness of the person. So the policy is lived experience informed, not system informed. And the methods we need to begin to look at is methods that take us clearer or nearer to those experiences. Ethnography, grounded theories, observing, talking, relating. Theories that actually tell us something radically different beyond the diagnostic attempt to actually define people. Within that, we need a lived experience framework and advocates, guidelines. But the research has got to be lived experience empowerment. The impact of any research is, what did this tell us about giving more power to people with lived experience? And so this is leading to a critical approach to the analysis of the system in which mental health units and mental health services emerge. So this model that we hope to develop through the lived experience aim is based upon empowerment, parity, but we're also looking from a legal framework, not at one moment in the life of the interest, we're looking at the life within the community, their holistic experiences through their families, their friends, their social convention. Ultimately, the outcome should be to raise lived experience clinicians. And the whole approach to the framework of research ideologically should be informed by lived experience, not the research controlling how lived experience are involved in those processes. So what's the impact? Very crucially, what we should be looking at is lived experience, ultimately care plans, treatment, impact analysis. Yeah? Lived experience should not be used as something that we feel concerned about using. It should be naturalized as a narrative to any other model: psychiatry, psychology, social work, OT. In each of those models, they should be given parity for when somebody is assessed under the Mental Health Act. And crucial guidelines in every aspect of the care and treatment of a personal lived experience. There should be specific guidelines and more specific guidelines in the research processes that make them much more ethical and representative. So, the recommendation from this first section is lived experience is knowledge and should be formulated and developed through theories, models, and should lead to an impact analysis. That there should be guidance for all researchers that are involved in policy practice, and mental health staff should be engaged in research and taught and trained in the appropriate way of co-production. At the front of this picture you see Ajibola Lewis, who's in the middle, and Sir Norman, who is from Chief Executive from SLAM, which is South London Maudsley Trust. In this training session they're looking at how do lived experience train professional. So in this picture you have medical staff, nurses and doctors and consultants through the Whiteness and Race Equality Network with service users, training people about every aspect of the mental health system, training researchers about their contractual obligation, their payment and qualification, and knowledge within the stakeholder map should be determined by their ability to work within a lived experience framework. So in this section, section 2 of the presentation is beginning to understand controversies around the challenge to service research. We must look historically at the important philosophical, psychiatric and research writers who actually created some damaging implications about people with lived experience. So Kaplan, who wrote some dangerous notions, what we call eugenics, that people with mental health issues or concerns were seen inferior. What he did, he dehumanized people with lived experience as if they weren't normal. Similarly, Henry Maudsley, and this is ironic that we have a person who has named after a psychiatry unit, actually believed in the moral insanity of people with mental health conditions, and that they needed to be controlled within the mental health unit. Hence, when you go to a mental health unit, they look like modern prisons from the Poor Lords. And sadly, one of our most renowned psychologists and psychiatrists of this time is Freud, who actually then said that people have problems around their personality and their childhood. But what's most problematic for Freud in his 1923 book around African society, he made the claim that they weren't human enough to have mental health issues or didn't have the emotional capacity to feel pain. So one of the biggest challenges or controversies is historically how people have been constructed as not even normal to have lived experiences or to actually enter into a rational, and I'll call this a white Eurocentric perspective. The major challenge here is how lived experience model theories have been neglected, how alternative ways of understanding mental health from a lived experience have denied throughout a range of the particular characteristics. Here I talk about race, and what Fanon talks about is the white skin, black mask. Some of the problems and challenges when people have to deny their experiences to put on a mask that means they can be accepted to whiteness. And this is what happened between the pre-production stage. This is the stage of slavery, the stage of colonialism that led to colonial abuse of the black psyche, of the black mind. Garvey begins to then address this in the philosophical model that there was no recognition to the lived experience of people that are different, that looked different, that spoke differently. Their lived experiences in controllably opposite to the world in which they were assumed to be compliant and integrated. And Wessing begins to address this for a really good book called Clinical Psychological Model to the Impact, the Symbolisms of the Damaging Impact of Post-Colonial and the Black Experiences that led to the lived experiences of an entire community being completely marginalized and misunderstood. And we can begin to look at in terms of the internet experiences of women of race, women of sexuality, actually outlined very clearly in the book of Bell Hooks, who was an important sociologist, and Angela Davis, who looked at the political issues facing black women in America during the 60s and the 70s. But this needs to be kind of linked to the methodological framework. The method of lived experience for Ladner did not represent the experiences of racism and mental health. And she challenged this as one of the major contributing factors that damaged the ability of researchers to be ethical, clear, and have ethical practice that represented the black experience. What is very controversial and saddened, and I'm sorry if this upset people, that the impact of the eradication and dismissal of theories of lived experience as a knowledge base has grave impact in the historical context of mental health. Cartwright was a psychologist who defined an illness called depomania. So if slaves ran away from the plantation, they could be sectioned and brought back. Fanon actually says these were people who were actually forced into identity, a lived experience that did not reflect their reality. In this pre-production, it's very clearly in this lecture we understand co-production is something we do now, pre-production of things that happened before. They inform the power relationships. The picture on the right are slaves that were forced into being hung, murdered, and killed, and restraint. The restraint process that we learned during the pre-production stage of slavery are now being replicated in our mental health system. And this is one of the challenges when we actually do researches. We've got to uncover some painful facts and realities about what happened to us and what we learned. Ajibola Lewis begins to do this in one of the most best written articles in the Lancet of Psychiatry, when she actually says what research is interested is in black men. Our article is Black Men Wanted for Restraint and Research. As we can see later on, these lived experiences in terms of research translate into practices now called community treatment orders, which is applied to 90% of black communities in this country. So what are the implications in terms of the challenges historically, the implication for practice, and also some of the controversies around lived experience? This PowerPoint just outlines there were some really political, immoral, and racist decisions being made by our funding bodies about where money is going to in terms of research. And if we look at the issue of race, which seems to be a topical issue, where we are now seeing more white researchers being given money by major research bodies and research mental health units to look at the black experiences. We can estimate that over £3 million is now pumped into white researchers, which is the new slavery of researchers, because there are no senior black researchers involved in these 4 research projects. And then this is a really important political challenge that we cannot repeat this major concern that's emerging upon that's leading to research that's looking at the experience of the cultural other who has no capital or power or equity to do their own research or to look at how they're being researched. Major issue that needs to be addressed in 2022, partially addressed, 2023 not addressed, was addressed by 2 papers I've written for the Lancet of Psychiatry. And from this paper I'm really concerned that there are very people with lived experience involved in academia, teaching, delivery of research programs. So we get this perspective, it's almost parallel to consultant, that knowledge is white. Some of the major challenges are political, they're historic and economical, and they are based upon our past. But in a personal way, one of the things we need to look at in terms of what creates that controversy and challenge is that we don't actually adopt Fanon's model about the mask that we actually wear that is actually stopping the experiences, particularly for black communities, of having a shared lived experience in terms of the rote research process. And this fails to emancipate from the psychological to diagnostic models of racism. So, in this relationship between the victim of racialized processes of mental health and those that perpetuate diagnostic models of racism, one is forced to take their mask away, which would be the black male, as you can see with the mask on, and the other one will be trying to dismantle this mask to find out what is taking place from the lived experience. So the challenge here about the controversy is that the system, the design of the system, historical superiority in terms of race, means that we don't work across racialized barriers. We work within a conceited and arrogant institutional forms of whiteness. So this is not about white people, it's about whiteness as historical forms of values, behaviors, and models that are used to design and diagnose race and lived experiences, in which black people are also the victim of, people with disability are also the victim of, and more, I think, more prominently, lesbian, gay, bisexual, transgender issues are not something we actually want to look at. So this is the major issue about how do we actually then take off and unmask to empower, whether it be the black other or other in terms of other protective characteristics. So at the end of section 2, I want to go into a bit more detail about what these challenges are. And this is not aimed at moving towards a binary or polarized thing around the black and the white perspective, but it's actually revealing that's where we're at the moment. We're into polarizations rather than complexity. And so beginning to remove the silence for a shared model lived experience, we need to then look at what is the black perspective that's missing from the research as a lived experience. People like Fanon and DeBois gives us the opportunity to take away the mask and the veil and to begin look more personally of why is it we're finding it difficult to work across these borders. Smallby gives an idea of things become racialized. Racialized as an experience, as a performance that's rarely challenged and that becomes institutional. But also that it becomes institutional within the research process for Ladder. And she shows from the period of slavery right through the period of depomania, right through the period of postmodernism, the same practices of divisions are leading to the same outcomes in terms of divisions of representation and diagnosis. And then we can begin to engage in some of the importance of white perspectives to research. Fanon and Foucault gives us the opportunity to begin to address how knowledge is actually institutionalized at particular types of people's experiences, but also the words that people use through the diagnostic framework and the research process, the scripts and narratives that give them power, they exclude the lived experience as a reputable body of model and research. Because the challenge now here, to change things, is to remap cultural relationships, to remap culture, and maybe to disempower and give power back. Because that's true sociological imagination. And within this change towards the way we work across colour line is to make it more visible. Now, visibility is not terms that we need more black people, and this is a major problem. I need a black person that looks like me. We need people conceptually that think very similar. Because if we're going to move to a transcultural co-production model, we need to begin to then racialize scripts and performances that are shared and agreed and have equal power in the lived experience process. We need to look at the racialized culture within the research process, that we do not continue this process of polarization, white researcher, black victim. We also need to be look at what does it mean across the color line in terms of racialized meaning in research, how we define research, how we ask questions, how we ask questions in terms of the interviews, how we actually make decisions about the interview, how does it inform our knowledge in terms of the recommendations that we actually do. So in this section 3, we're going to move from what we think are the challenges and then begin to look at how can we look at the resources that's going to benefit survivor research. Some of them will actually have emerged from some of the great book in that survivor research, and there's a list of books done by Peter Welfords and articles that I produced in terms of co-production. So at the end of section 2, we began to look at some of the challenges of controversy, but we need to then look at some of the things that we need to do from the support angle about how do we unmask in our values from what I call the pre-production stage, the stage before co-production, where a lot of the ethical and power and models and process were developed through slavery from the white Eurocentric perspective. And so then we need to maybe go back to values from those historical values that are given to us as acceptable institutional process and cultures. What I mean is that this is how research is done, because research is about power and it's about power of meaning. And so we need to look at how do we then challenge those processes so we depoliticize to politicize values from the pre-production stage. That's not dismantling them, it's actually then saying that to involve lived experience as a toolkit, we need to then recognize and value alternative frameworks that we may find difficult. And these are different ways. We have the emergence of more of a feminist approach. We don't have the Afrocentric or the disabilitism approach, but there are Afrocentric theories that have been crucial. And we talked about Ladner, Death of White Sociology, crucial book that then says lived experience does not recognize the Afrocentric perspective in research. And so then we need to then begin to do that, but then how do we personalize it and how do we make it conscious? So there's a discussion to be had, a reflective process about what I think I know, which is implicit, but what do I need to know, which is implicit? How do I talk to people? How do I have that dialogue? How do I have that culture of sharing or declaring the impact of a value of lived experience, particularly in race equality work, when we've seen this huge investment, which we mentioned in section 2, of white researchers defining the lived reality of the black experiences to white research bodies. And then there's an issue here, there's a professional issue, there's a duty of care to racialized care. If we continue to embrace a systems approach which is enabling and empowering people to speak on behalf of lived experience, then we're doing a great disservice, and we may be replicating some of the historical values we talked about that emerged from Kaplan, yeah, from people like Fanon, that the eugenics in mental health is the failure of the lived experience reality to be given recognition about how they challenge these historical contexts. And so that in the research process, in this pre-production stage, the things that happen before we even sit together, before we actually recognize lived experience, is challenging the contradiction of protective characteristics that we ourselves, whether we are black men, may have contradictory values towards people of other characteristics, which could be lesbian, gay communities, faith, religion. Whiteness has a central issue in the contradiction of its values when it looks at the other. So these are some of the things that challenge us. And then how do we make these unconscious oppositional values pertinent and relevant? We can't say and hide behind the epistemology or the ontology of, yes, I'm objective, I'm distance, I've got this framework that's based upon a method that means that my values do not. No, we've got to be honest, because we've got to make sure, how does this operate in our practice? What theories do we bring into our methods that are informing this relationship? We need to measure that more clearly in the relationship with people with lived experience. So the lived experience develops a knowledge that's reflective and changes the practice of the people it intervenes with and makes sense of. So there's a need for more equality in mental health systems and practices. The allocation of funds, how money is given in terms of the guidance and the recommendations about how a lived experience is involved and embraced throughout the whole process. How then the lived experience has an impact analysis in terms of the research process. So in this toolkit and some resources that we can use must be underpinned by some ideas of what we do. So it's something, how do we connect different approaches to the ontological, which is really about the world we're in, against the epistemological, this is the knowledge. So it's really trying to bring together various models, which could be Eurocentric, could be Afrocentric, could be feminist. How do we then bring that together into the interconnected? What are the challenges when we actually do this? Can we come to some shared meaning? Can lived experience have a shared reality with clinical practice and addresses the aims which we had talked about the legal framework in terms of the Mental Health Use of Forces Act, particularly in terms of diagnosis? This is crucial to the whole debate about why we're doing this, because we want to make sure diagnosis as a term has a variety of different components that leads to different outcomes. So it's not just about my medical, or it's not just about the mental illness. And to do that, as we said before, we need to connect Afrocentric and look at some of the issues that are going to help us in terms of the lived experience of people bringing their mask off, as we said, look at the symbolisms, but look at this issue of whiteness. Whiteness as the dominant process of doing research and what that imposes on people who are not white. And we can share this in terms of power dynamics between people who are disabled and non-disabled. And gender is right throughout as a theoretical framework, because it's also about engaging and sharing those experiences. But also, again, we've got to go to the outcome. Why are we doing it? What's it's going to address? Firstly, we talk about diagnosis, but obviously we want to address some of the concerning emergent themes that are taking place in mental health care, with the huge number of people who are now compulsorily admitted to mental health services in Britain Society, which is the highest in Europe. The huge number, unfortunately, again, this repeated theme of black men who are restrained under the Mental Health Act, and people that have died through restraint. Alabola Lewis, Sean Riggs. The number is concerning and brings a tear to my eye as I do this lecture. But then we need to add in the other alternative issues around gender and class, and begin to look at issues that can link Ladner, that how we then ensure that our approach is not essentially white, or for Foucault, it's not essentially based upon a dominant masculinity approach, but also we're moving to something that's quite difficult, because we are so focused on polarization between lived experience and non-lived experience, without recognizing people with lived experience have interconnected identities, maybe outside their lived experiences, but also how the care plan is really based upon a very formalized medical approach to the assessment of people's needs. And that's something that we need to change in terms of the research, in terms of how the care plan needs to be more formalized into lived experience models. And then we need to begin to bring in this other interconnected issue that's raised by Brailsford, and I think it's crucial because it actually is relevant to race. I would expect most people's section under the Mental Health Act will be working class origins, whatever the protected characteristics. And then we need to challenge those privileges as well, because it has a very important implication for discharge. We now know that data shows that most people cannot get discharged because they cannot afford to live in accommodation, they cannot afford the right food, they cannot afford the medication of fitness. So we need to look at from a lived experience the elements of class and that people from those interconnected issues are addressing those through the research process. Because the whole thing is about the other, the other, the other. And the last thing for me is about the model is to ensure that we're not using the research to reaffirm some of those historical belief systems that came out around depomania, that people run away from a mental health system, they do not involve in mental health care and treatment, that they can be brought back. Because unfortunately, this has led to one of the most institutionally racist challenges in mental health care. 90% of people coming back are black men, which is really kind of concerning. So we in the Whiteness and Race Equality Network with my good friend John have been working with white consultant psychiatrists and white researchers to look at how do we work across the colour line and how do we develop much more integrated shared meaning systems of research which incorporates lived experience from the start right to the end of that research process. So the aim of this co-production toolkit is a really basic aim about how we then resolve the polarized, unshared meaning between consultants and other professional lived experience. But it's particularly relevant to research as a framework where the lived experience of a psychiatrist or researcher begins to look at what we call non-oppositional ways in looking at how we share our experiences, how we come back to the first person, which is me, the authentic, and how then we get to know the first person experience of the consultant, and it begins to humanize relationship rather than formalize it within the diagnostic framework. So the first part of this toolkit is beginning to look at what we call developing the co-production icebreaker. And so the two individuals talking can be the researcher and the lived experience researcher talking about image themes, things that make them who they are. And it can be a basic sharing of their family, their schools, their relationships, things that affect them in their life and their decision making, things that inform their perception of each other as well. This can be really creative. It can be a picture, it can be a drawing, it can be pictures, it can be image. It doesn't need to be formalized in terms of writing. The aim of part one of this co-production lived experience framework is really to begin to address some of the challenges we talked about in section 2. How we historically be polarized, how we then lead to values of particular heritage that may dehumanize, and how we get back to humanizing the relationship that's important in terms of research. But it's also addressing the economic and political challenge about how do we then give power back to have the most effective outcome when we're doing lived experience research. So in part 2 of the co-production model is to begin to move away from the sharing and discussion to begin to look more specifically about how we shape a new way of doing research. And that means that how we then incorporate lived experience in a dual discussion from the start of the process that gives recognition to some of the icons that have led this debate, like Peter Belford, about the importance of recognizing it as a legitimate legal and ethical framework, and also a framework that addresses some of the things we touched in terms of ontological, just about our experiences and bringing them together. The things we talked about, the epistemological, which can be quite difficult, and then also some of the methodology as well. In the research journey from lived experience, it's quite clear we do start off with a challenge, a question, but to then say, well, who's funding this project? Is it going to be of benefit to people with lived experience? How do we then begin to introduce an impact analysis? and how a lived experience involved in the governance framework and the guidance that decide whether a research should go ahead, and how we're going to give parity to the different partners, but also the practice implications for the research is crucial. And also that practice implication addresses the similar challenges of parity for lived experience in those postmodernist settings, those spaces of admission toward, to discharge, to back into community are crucial. So in this kind of toolkit, which I think most people mention, is the importance of co-production and reflection. But it's also about the process of doing reflection together, being very clear about the boundaries of the reflection, not personalized, but also being professionalized in the values that we bring and its impact on the work, on the process. Reflection every moment that we are engaged in each aspect of the delivery process, that we reflect. We reflect on individually for ourselves what the themes that are emerging. And also, one of the biggest problems is not to be afraid to change and adjust and adapt and not be constrained by political and economical demands on the research that may be informed by certain governance requirements. But also to address the power dynamics in terms of issues around co-production, issues around protective characteristics, issues around power that are crucially, and also to enshrine throughout every aspect that the lived experience is the central strategic driver that informs that we work in the future. And when we talk in our practice, just like we say in equality impact analysis, a lived experience impact analysis should be an intricate and institutional framework from the research right through to the practice that really recognizes how we take seriously the contribution, the models and the theories that are giving people with lived experience parity. So this is a toolkit which is a variety of co-production stages, which is really applicable to lived experience and research. Hopefully it addresses some of the key ideas about what lived experience is actually about, which we discuss in section 1 of this presentation. That it's really about respecting the wishes and the legacy of Peter Brailsford. It's really respecting the fact that it's part of a legal framework that we need to address. It's an important part of a knowledge framework that we need to address as well. And when we go through those different stages and conclusion to this section, that in each stage from the epistemological to the impact is crucially relevant. But it also has to inform a co-production that is actually looking at processes for participants. It needs to look at not the dismantling of some of the pre-production process that have given powers to people who haven't got lived experience or may be seen as clinician, but it needs to reconstruct those words so they begin to understand this is not about disempowerment, this is about shared powering. Because we have the opportunity here to produce something that's rare and exciting with the lived experience. A reality that's based upon authentic first-person experiences is the closest scientific observation that we can get to change wider implications in the structural worlds in which mental health actually operates. And not just in terms of the world, but in the community, in the society that we actually live on, that mental health is the strategic driver for change, particularly in the research. We can then look at a pre-production stage that leads to a really positive post-production stage for people who have mental health issues, that people who actually are constructed as lived experience, but also for people who are in the co-production relationships where they feel they are powerless and depoliticized and actually been used as capital. I've been through those experiences as a black person, that my lived experience is using me to victimize or reinforce the stereotype. Because in the last section, we need to look at how this is going to be used to reshape, reconfigure, and re empower a community of people, unfortunately, in this stage of poor living standards, poor housing, poor education. The lived experience communities across the co production processes of working are suffering the worst mental health services in modern Britain. Hi, it's been a real pleasure to share my personal experience as a black man with lived experience. It's been a privilege to say that we have the possibility for people with lived experience to really affect mental health practices. As students changes, you are really the most important people in that motivation and direction. I wish you the best in your studies. Love and take care.